Good morning to everyone, and thank you, of course, to BD, and thank you for the organizer of this very interesting meeting today. It's my pleasure today to have the opportunity to share and to discuss about the use of mechanical arteriothrombectomy devices in two really tricky, complex situations like in-stent or bypass occlusion. My disclosure. The disclaimer. Okay, the first chapter of my presentation is focused on the use of Rotarex in in-stent restenosis or occlusion. Of course, we know well that the use of stent improves the result of PTA alone at the FEMPOP level, but the use of stent in this area is related with a high percentage of restenosis and occlusion. This meta-analysis show that probably the best treatment for this type of lesion is yet to come. We know well that the PTA alone is not effective. The use of drug-eluting balloon alone is effective, but only in a really short restenosis, then in Tosaka 1 lesion. For Tosaka 2 and Tosaka 3 lesion, then the most complex situation, the bulking seems to be the key of treatment. Why the debulking is so important? The debulking is important, first of all, to remove the intimal hyperplasia, to obtain an effective lumen gain, and finally, in case of a total occlusion, to remove an eventual thrombotic material. The neointimal hyperplasia, we know well that is completely different than the novo lesion. More than 80% is an extracellular component, and then at the beginning of our procedure, we have to remove this to improve the drug delivery at the level of the smooth muscle cells. And also the intimal hyperplasia is a reason of lumen loss, and if we apply the Hagen-Poiseuille law, then this law shows that there is a 4-power relationship between the flow rate and the vessel radius. A lumen loss around 50% is a reason of flow reduction higher than 90%. And finally, in case of a total occlusion of the stent, the central portion probably is a thrombotic material, and then during our treatment, at the beginning of our treatment, we have to remove and to use then a thrombectomy, an effective thrombectomy device to remove this material. To perform the debulking, we can use some different devices, a atherectomy, excimer laser, mechanical arteriothrombectomy device. These reviews show that Rotarex S seems to have not worse result in follow-up than the other one. In our experience, in our opinion, Rotarex S seems to have some advantages. The first one is that this is a really thrombectomy device, and then is able to remove every type of thrombotic material in case of a total occlusion. And also, at the tip of the catheter, the rotating helix is completely covered and without blades. And then, in my opinion, this reduces the risk of stent barbs interaction, stent fractures. This is just an example, and in a very long in-stent restenosis without stent fracture, then a typical Tosaka 2 lesion. In this case, we use a Rotarex 8 French. This in order to obtain the debulk and the removal of the hyperplasia, and this is the final result with a complete recanalization of this stent without a residual stenosis. These are two more complex situations than a complete occlusion of the stent, a Tosaka 3 lesion. In this case, the use of Rotarex is not only in order to remove the hyperplasia, but also to remove the thrombotic material, and these are our final result with a complete restoration of the flow. The second part of my talk is dedicated to the use of Rotarex in a more complex situation, that is the bypass failure. We know that the bypass failure, above all in patients with CLTI, is a really dangerous situation for life and for limb, and this is related with a high percentage of limb loss at 2 years. We can treat this with open surgery, of course, with local thrombolysis, or eventually using mechanical atherothrombectomy devices. Considering open surgery, of course, ruling out the Fogarty thromboembolectomy due to the no acceptable result, open surgery is based on the redo bypass surgery, but we know well that I'm a vascular surgeon, then I hate a patient like this with many previous revascularization in the same leg, and we know well that this type of patient are really, really tricky. And also in case of the absence of the autologous vein, the follow-up and the result are really poor. Therefore, the local thrombolysis has become an alternative treatment for this patient, but we know the complication of thrombolysis, and also local thrombolysis is not effective in case of subacute or chronic occlusion, or in patient with a really acute ischemia is too slow to restore the flow. This is the reason why 10 years ago we have started to use the mechanical atherothrombectomy devices in patients with bypass failure. And with this device it's possible to recanalize every type of occluded bypass, then acute, subacute and chronic, above the knee like this or below the knee, and then more complex like this. Today I'm really proud to have the opportunity also to present the result of our paper published last year on VASA. The aim of this paper is to compare not only the clinical outcome but also the treatment cost between open surgery and Rotarex S in patients with acute, subacute and chronic bypass failure. These are our clinical and cost endpoints. We apply in this case the cost effectiveness analysis, then the ratio between the cost of HILT gain and the gain in HILT. This in order to evaluate the possible dominant therapy. This is our study, a continuous series of 48 occluded bypass, 17 treated with open surgery and 41 treated with Rotarex. No differences in demographic characteristic. The only difference is in gender distribution, because in the open surgical group all patients were male, and no differences regarding comorbidities. All these patients with critical limb ischemia, then not patient with claudication, from Rutherford 4 to Rutherford 6, most of them in Rutherford 5 class, then with tissue loss. No differences regarding the time of occlusion between these two groups, and more than 70% with a subacute or chronic occlusion, and then not treatable for local thrombolysis. Again, complete homogeneous group considering the site of the distal anastomosis, the outflow vessel, the material of the bypass. Regarding the treatment, these are the most important differences. The duration of operation is about the half in the Rotarex group. Of course, the blood flow transfusion are significantly lower, and also the length of hospitalization is about 1/3 in the Rotarex group. During follow-up, no differences considering the reocclusion rate. The reocclusion rate is quite acceptable and completely in line with literature data when we consider the redo bypass surgery or the use of local thrombolysis. The only difference is in patency duration, because this is significantly longer after Rotarex use. Sorry. Again, considering the follow-up, no differences in death rate, in limb salvage rate, and this is quite good, around 90% in both groups. The last part of my presentation of my paper is dedicated to the cost evaluation. This table summarizes the cost, but if we consider separately the intraoperative and the post-operative period, we can see well that in the intraoperative period, of course, the Rotarex procedure is more expensive due to the cost of the device, due to the cost of the endovascular materials. But if we consider the post-operative and the perioperative period, the Rotarex procedure is significantly less expensive due to the less IQ stay and also due to the faster discharge. And then in conclusion, if we apply the cost effectiveness analysis, the Rotarex procedure is a dominant therapy, and this is the reason why in this moment is our first choice for bypass occlusion in our department. Then in conclusion, the take-home message of my presentation of my paper is that, of course, when we compare open surgery with Rotarex, this Rotarex is less invasive, but also less time-consuming, less expensive, and producing a greater health benefit. Thank you a lot for your time.
Thank you very much, Bruno. Great overview. I'm sure there will be questions, remarks. The audience, I look at Wouter. Wouter has a remark or a question.
No, I think it's a beautiful way to present this kind of data, and it's the way we have to think. But I was thinking 10 days surgery hospital stay. That's not our policy for thrombectomy. Normally we let the patient 3 days or 4 days stay in hospital.
But was it a good bypass, am I right?
No, yeah, for redo bypass is 11 days. The average for Rotarex is 3.7.
Redo surgery, thrombectomy,
yeah,
doesn't have to stay 10 days in the hospital.
No, the redo bypass surgery, 10 days.
It's a new bypass, eh?
Yeah, the new bypass. For the new bypass surgery. No, for the Rotarex is between 3 and 4 days because many of these patients are patients with a lesion into the foot, and then it's not possible to discharge the day after the procedure for pain, for something like this.
Lieben, you have a question?
Yes, I was curious about your adjunctive therapy after Rotarex in Tosaka 3, let's say the difficult in-stent occlusions. Are you sticking with DCB, or do you think there is room for debulking and then putting like long covered stents? Is there an additional rationale for that, to have more room? Because DCB, I'm still doubting even after Rotarex.
Now, usually when I able to obtain a very good result at the end, like in the first case with a longer stenosis, I use DCB and don't place another stent into the previous stent. But of course, the idea in case of a complete occlusion is to obtain a channel, a new channel, remove the subacute or acute thrombotic material, and then if there is at the end remains something, I place covered stent.
Maybe the other panelists, what are your ideas about long, difficult lesions in stents?
Yeah, I mean, if you look at literature, if you look at non-Rotarex, so you just go angioplasty, the results at 1 year between a normal angioplasty and DCB are the same. And it looks like with adjunctive thrombectomy and the bulking, then the DCB does better. Still, I think it's a very Achilles tendon. And actually, also something for juniors, when you have an occlusion of a bypass or a stent, always look at causes. It could be that the patient didn't take the therapy, but it could be that some sort of distal stenosis, distal disease, which then all of a sudden made the bypass occluding.
Okay, so a short question from my side, financial question. You compared here very clear with open surgery, and it was clearly in favor of the Rotarex. also a lot of people, I think, our practices also in the room, the alternative for Rotarex is thrombolysis catheter. Do you have any idea about costs comparison between catheter-guided thrombolysis versus Rotarex? So also there in terms of costs, during the procedure, Rotarex is quite more expensive, but then your thrombolysis is staying 2 days on intensive care. What is changing the cost plate again? So what is your opinion on this? Do you have data? Because I want to convince my government to reimburse in Belgium devices like this.
No, unfortunately, I don't have data because I started 10 years ago to use Rotarex, and then I stopped completely with thrombolysis in this patient. Then I think to stay 2 years in IQ or 3 days, and also the cost of thrombolysis are not low. And then, but I don't have data to compare this.
Thank you very much. Thank you.
Thank you.
So